Good afternoon. You're all welcome. So let's know where you're calling in from. It would be nice for us to get to know each other before we get started. We still have a few minutes to introduce ourselves and get excited here. So let's just know where you're dialing in from in the chat room. My name is Chineye Rajafa, and I'll be moderating the event for today. So please, in the chat room, just tell us where you're calling in from. Are you calling in from Lagos, Abuja, Nigeria, Ghana, Tanzania, wherever you're calling in from? Please just say hello to us in the chat room. You can say hello in your native dialect. That will be fine. That will be exciting. So let's just look at the chat room and say hi to each other and be sure that we're all awake and ready for this session. So Ndewonu, I'm calling in from Lagos, Nigeria. Can you all hear me? Hello.
Yes, we can hear you. Thank you.
Yes, I can hear you.
Beautiful. So let's keep the chat room buzzing. So let us know where you're dialing in. Thank you so much, Helen.
The chat.
Thank you so much, Dr.
Private.
Faith.
You can't get everybody on the chat. You need to open it up.
Okay, so please let's open it up. IT, we need the chat room opened up. Let's be sure. How about the question and answer room? Is it opened up? Please be sure you can send us a message there too. Want to be sure that everything is working fine. Please let me know if you can say hi to us. Try saying hi in the question and answer room. Okay, good. So I think someone has said, okay, beautiful. So that is open, but the chat room is closed. Okay. Okay, cool. So I can see that you can send me messages in the question. Okay. Yeah, nice. Now I'm saying it. Hello from England. Hi, SA. How you doing? Hello from Abu Dhabi. Hi, thank you, Linda, for joining us. Thank you so much. Hello, everyone. So you can drop a message in the question and answer room. Yes, you can. I can see a message there. So that's good. So thank you so much, everyone. Yes, thank you so much from England. Hi. It's good to have you here. Oh, cool. Now the chat room is open.
Okay, good afternoon, everyone. Welcome to, okay.
Okay. Thank you so very much. Thank you, guys. I can see your comments in the chat room. Thank you so very much for joining in. It's good to have you here. We're going straight into the meeting. Sorry, I had some noise in the background I had to take care of. Okay, so I hope it's clear now. Can you still hear the noise?
No.
No, we can't. Please proceed. Thank you.
Okay, good. Some blessed children are in the background. They were in the background. Everybody's on holiday, so thank you. I can see you, Calabar, from England, from Uyo. Ah, yes. No, we're the Lagosians. Where are the Lagosians hiding? Okay, so thank you so much, everyone. It's good to have you all here. I look forward to having an exciting session with everyone here today. So let's just go straight into the reason why we're here. We are the Pistis Foundation, and we drive our initiatives through education. Sorry, excuse me. Okay, sorry, we're the Pistis Foundation and we drive our initiatives through education, health, and shelter. One of the overarching objectives under our health program is to offer health education and also to promote activities targeted towards beneficiaries. And here, that's the reason why we have webinars like this. So our webinars have three basic objectives, one of which is to offer free online health education to target audience. Another objective we hope to achieve with our webinars is to promote health and safe living as well as mental wholeness. And then finally, we also engage experts to bridge knowledge gap in a selected health topic. And that's one of the objectives we're going to be achieving today. According to the Nigerian Medical Association, there are over 24,000 actively licensed physicians caring for over 200 million Nigerians. And this is as a result of the current brain drain in the nation. So today's webinar will be to address the brain drain in Nigeria, the issues around it, and how we can safeguard our health as Nigerians. I'm sure we're all excited to know what we can do to safeguard our health and how we can help to mitigate the brain drain syndrome in Nigeria currently. So with me today, I want to introduce my co-moderator, Louis Isemede. Louis, you can say good afternoon to everyone. Louis is here. Hi, Louis.
Good afternoon, everyone. Hello, Elia. Good afternoon.
Yeah, we also have with us, we have three experts and seasoned professionals in our midst. Dr. Faith Ekpekurede. We also have Mr. Fisayo Okunsoya, and then we have Dr. John Nadi. So everyone, so just say hello to the speakers, Dr. Faith, Mr. Fisayo, and Dr. John. They will be dissecting the topic for us today. Hi, Dr. Faith. Hi, Mr. Fisayo.
Hello.
Hi, Dr. John. Welcome. You're welcome to the webinar. Thank you so much for taking out your time. Thank you so much. We really appreciate you for taking out your time to do this. It's really an honor to have you here. Thank you so much. Thank you, Pray. Thank you so much. You guys, please appreciate them in the chat room. It's very important that you keep the appreciations coming in. Thank you so much, because we really appreciate them. So we'll have their sessions. They will have about 20 minutes to speak on each of the topics that they've been given. And after their sessions, we'll have questions and answers. So please stay tuned and drop your questions in the question and answer room so that we don't mix it up with the chats, because the chat is where we say hi and hellos and all the messages, but the question and answer room is actually for questions so that we can easily pick it out and be able to ask the question so that we don't miss anybody's question. So thank you so much, everyone. We will start our session today with Dr. Faith, and I would be Louis should please give us an introduction of Dr. Faith and as she presents. Thank you.
Thank you so much, Inaya. Thank you for taking us through that with a lovely introduction. Thank you everyone for being present. Thank you as well to those who are joining us on Facebook or Instagram Live. We're glad to have you with us. Similarly to those who are here on Zoom, If you have any comments or questions, please put them in the comment section. Our team over there would be able to take them and pass them on to the speakers. Can I just also ask that if you have specific questions as we go through the day, that you please put your questions in the Q&A and indicate which of the speakers your questions are directed to. We'll be taking, the Q&A box is open already. So as soon as Dr. Faith starts, you can begin to put your questions in there and we will look at everything at the end of the day. So thank you so much. I will just share a little story of something that happened with my friend. She posted this on Facebook sometime last year. And she mentioned that she needed a speech therapist for her daughter. And all the ones that she had been using previously in Abuja for some reason had all relocated. So she literally had to get one from Lagos, paid for her to move all the way to Abuja for the period that she needed her services. And you can imagine how expensive that was. Well, this year, this happened last year. This year, she gets a Happy New Year message from this therapist with a foreign number. So even the therapist that she had managed to use throughout last year had now, as we would say, jackpot. And this really has been the reality for many people, especially if you maybe have a specialist doctor you've been seeing, maybe all of a sudden they're no longer available, or you go to the hospital and you have to spend longer than usual in the hospital managing because of the reduced number of doctors and healthcare professionals that we have. And so this brain drain is a reality, but how do we mitigate the effects of this on our personal health? That's what Dr. Faith is going to be talking to us about. So I'm just going to introduce Dr. Faith Ekwekurede, who is a woman that Jesus loves. That's how she describes herself, a woman that Jesus loves. She's a 1993 medical graduate of the University of Benin College of Medical Sciences. After graduation, she proceeded to work and train in the Health Services Executive in the Republic of Ireland, and then the National Health Services, the NHS in England, where she obtained her MRCEM equivalent certification. She's a member of the American Heart Association faculty in Nigeria for both the Basic Life Support, BLS, and the Advanced Life Support, ACLS. She's certified by Harvard Center for Medical Simulation as a healthcare simulation instructor. And she has a membership of the Institute of Leadership Management UK and is a certified stress management trainer and coach for the Stress Management Society UK. She's currently the medical director at the Reddington Hospital in VI, as well as the clinical lead emergency service Reddington Hospitals Group. She's happily married to a God lover and life coach, engineer Tunde Ekwekurede, and together they have 4 precious and blessed children. Please join me in giving a virtual clap as we invite Dr. Faith as she takes over the webinar. So please let's use the emojis to welcome Dr. Faith as she takes over.
Sorry, I think I had a glitch there. Sorry about that. I don't know what happened. Sorry, I had a glitch. I don't know what exactly happened because the internet is working.
Dr. Faith, you can continue.
Thank you.
Thank you.
So I just share my slides now and take it from there. Okay. Can we see my slide, please?
Yes, we can.
Thank you. Sorry about that initial glitch. And I want to say thank you to the Pistis Foundation team for giving me the opportunity to share on this very crucial topic, something I'm very passionate about. And I want to say thank you to all the participants who have joined in, and I'm looking forward to a very interactive time of learning and growth. So just going through a bit of preambles about brain drain. To ourselves, probably very by nature.
Dr. Faith, you're muted. Dr. Faith, it appears that you're muted. So if you can unmute so we can hear you.
Okay, sorry about that. So I was at the point of saying that brain drain is not altogether negative. There's actually the brain gain if brain drain is properly managed. And that's actually the bit of preambles here. First to say that it's not peculiar to Nigeria. But having said that, it does seem to, at the moment, that Nigeria as a country, for us, we don't seem to be moving in the right direction with regards to brain drain. If you look at that chart on the right, you'd actually be able to see that most of the other countries like Rwanda, Ghana, and most of the countries you see there, especially the first three, seem to be moving in the right direction with brain drain. What that means is, over time, some countries are actually able to harness the power of the brain drain. In essence, you have people who go out there, gain the skills, and come back to the country, or they put policies in place to ensure that they actually are able to harness the power of the knowledge and the skills that have been acquired by these people who have gone out of the country to train and work. Now, the first three countries you see there have been able to harness that. But if you come to the last three countries at the bottom, you find Nigeria doing about 95% in the wrong direction and 5% in the right direction. And I'm so proud of Pistis Foundation, because this sort of meetings, we need to be having them more frequently, because to bring ourselves up to speed and help ourselves see that brain drain is not altogether a negative phenomenon, but something we can actually harness effectively to make our country better. India today is become a health tourist destination. The reason for that is that there was a massive brain drain in India for a while, and then now most of those people are headed back to their country and made their healthcare system much more sustainable, and we are going there to access care. And not just India, but a lot of other countries. I'll just move on. Now, what are the implications of the brain drain? You find out the major thing is, the previous slide, we were talking about, at the end of COVID, the Nigerian Medical and Dental Council had about 80,000 doctors registered. But the number on ground in Nigeria were about 30,000. And what that implies is that the number who are on ground, you have the doctor to patient or population ratio very, very meager. And what that translates to is that the doctors who are on ground have to do a lot more to be able to provide health care to the large number of patients. And that translates to job stress and occupational burnout. You have a low quality of service to delivery users. And then, of course, when people can't access healthcare appropriately, you find them turning to alternative sources of healthcare and going to unorthodox practices and finally ending up in the hospital in very moribund states. You have poor medical training as well, because most of those who are supposed to teach the body medical team are actually jetting out of the country. And then, of course, at the bottom of it, the most important, those last two, increased morbidity and increased mortality. These are the implications of the brain drain. Now, how the thrust of my engagement with us this afternoon is actually to talk about knowing that this is what's going on and knowing that we're in the middle of it and we're not going in the right direction with it. How do we manage our health in the midst of all this? Now, I want to take it first on the individual basis. I'm looking at a population of Nigerians, and I try to do this with my patients since I came back, to encourage my patients to be well informed, not to see the doctor or the clinician or the nurse or the pharmacist as that God up there who just tells you everything and you just swallow it hook, line, and sinker. But as a patient, as an individual, I'm encouraging you today to be well informed. Right now, we have a lot of information out there. Google can help you, but you can actually even go into the health store and buy very useful books that will help you educate yourself on your health and how to look after your health. The next line for an individual is to focus on prevention, because if we look at after ourselves, then we will actually be able to prevent ourselves from going into the hospital with an emergency and then having to deal with the fact that the doctors are not enough on ground. So how do we focus on prevention? We're looking at maintenance of personal hygiene. That's so important. Our environment, how do we look after it? It doesn't have to be affluent for it to be neat. Growing up as a child, we grew up in very poor environments, but we kept them neat. Then, of course, we're looking at balanced diet. In this day and time, we're having a discussion in my clinic, in my hospital. We started what we call the weight and stress management clinic. To help people lose weight and manage their stress. And we did find out that our lifestyle is so different from the lifestyle of our parents. And so we're dealing with a peculiar set of diseases and health conditions which our parents didn't have to do. And the reason is our lifestyle, if you don't mind, down and the remote control does everything. We need to be able to exercise, to move about more. These are things our parents don't do. Many of Stop Cooking, Stop Shop, do you ask yourself, what sort of vegetable oil are they using? What sort of oils are they using? Is this food, does it have the right amount of everything you need? Okay. Can we hear me?
Yes, we can hear you. It was breaking a bit. Maybe if you turn off your video, it might help.
Okay, thank you very much. I'll
You're
do
welcome.
that. It's all right. Okay.
It looks like we're good, Dr. Faith, so you can just continue.
We're good. Okay.
Yes, thank you.
Sorry, I couldn't get that sorted.
It's okay.
So I was just at the point of the prevention for us as individuals, the recommendations. So, and then of course, exercise and rest and stress. We live in a very stressful Lagos. Managing stress is very important, and I'd encourage us to join webinars to read a lot around stress. I do sessions on stress management, and you could meet me after this and we could talk. And then of course, to avoid illicit intake of substances. By that, I mean cigarettes, alcohol, monitor the amount you take. And then in this day and age, I'd encourage every family here to make sure you have a first aid box at home. Always, that is, make sure you have one. And then understand basic first aid. We do trainings on basic first aid, knowing what to do when a child is choking, knowing what to do when there's a fever, an injury, and all of that. And then participate in CPR courses. I'm a certified cardiopulmonary resuscitation trainer and basic life support as well as advanced. But for you, I think basic CPR will be very important. What do you do if somebody has chest pain? You should be able to know what to do if somebody has chest pain. Enroll in some form of health insurance is the last bit there. There are different levels of health insurance, and sometimes it just takes a bit of planning of our finances. I know things are stretched and tough, but please, I will encourage every one of us here to have some form of health insurance. And so that's actually, I'm actually honing more on the individual, because I know my host speakers today are going to speak a lot more about the government and public policies that will help mitigate the way things are in this dispensation. So these are just the major recommendations at the moment I'd want to encourage all of us to get involved in. And I think just a bit on the public one, I'd want to talk about what the Pistis Foundation does. This sort of programs, webinars are just so key. If every church, every organization, every religious organization takes out time to organize things like this, and even in our little communities, we can take out time to organize things like this, we'll go a long way to educating ourselves and helping to mitigate the impact of the brain drain. And if you're a clinician here, you could actually do a lot on social media. Use the social media much more profitably than you probably have used it, and educate the populace about their health. And there are some already doing it, and I want to commend them for that. During the COVID pandemic, there were so many doctors on social media actually educating the populace about what to do and how to prevent themselves from coming down with the COVID. And right now, we can do the same thing amidst the brain drain. Every clinician here, every nurse, every doctor, every pharmacist, let's make use of the social media space to educate the populace about their health. And then when we interface with our patients in various health organizations, let there be a lot of empathy. Because yes, we're few in number, but the right attitude and mindset could actually go a long way, and being able to manage the patient holistically, not just managing a part of them, but taking a bit of time to educate them about their health about what to do and what not to do, asking questions that actually reveal the root cause of their problems and dealing with it. These are some of the few things I think we can do, because my time is short and I've had quite some significant glitches with my network. But I do think with these few points, I have been able to pass across some vital information to the rest of us. I forgot to mention a very important program which the Pistis Foundation actually anchor every year. That's the UBOMI. A lot of the health education and things are preventive, but UBOMI is curative, where doctors come from all over the world to actually skills and care for the least, those who can't afford it. So people actually are able to access care, access surgical procedures at no cost because of the foundation. And imagine that every organization, every church does this sort of intervention. It will go a long way to mitigating the impact of the brain drain on our system. And then, of course, I want to say finally that there is a brain gain happening. I, for one, practiced in the UK as an active emergency physician for about 10 years. And August last year, I came back to the country. And we need to create an enabling environment for clinicians who want to come back home to be able to engage with the system. And currently on ground, I'm doing exactly that for some of my some of my colleagues who would want to practice in the system. And so what I do, I get them engaged, first of all, in education. So when we have clinical meetings, we actually do it virtually so that some of our colleagues from outside the country can be a part and actually bring their wealth of experience to bear on our younger colleagues, and the learning is much more robust. And then, of course, inviting these international clinicians who are good at what they do to actually come into the country and perform what they do best and give our populace the opportunity to actually be able to benefit from those skills without the people necessarily having to return home. They can actually come periodically and practice their skills, because those of us who are on ground are providing the enabling environment and facilitating things for them. Those are some of the things we do in my practice that has gone a long way to mitigate the impact of the brain drain. At this point, I want to say thank you. And once again, I apologize for all the glitches with my network. Thank you for your time and your attentiveness. I'd hand over to the moderator now.
Thank you so much, Dr. Faith. Thank you so very much. Please let's give Dr. Faith a round of applause in the chat room. Let's share her some love and tell her how much we appreciate her. Dr. Faith, thank you so much. Despite the glitch, we were able to get some helpful tips and some actionable points that we can start to make some changes in maintaining and sustaining our health despite the brain drain. One of the things that you mentioned that was particularly interesting to me was stress management. Stress management, because as a result of the brain drain, there's obviously so much stress. Not just the brain drain, everybody's going through stress. The elections brought stress of its own. Everybody's under some kind of stress or the other, mental stress, physical stress, emotional stress. So I would really want you to, I don't know if you have someone who is in the chat room or who is in the meeting that can help us, that can drop, more a link to some of those sessions that you have that we can exploit and, to take advantage of to be able to mitigate the stress. So many people feel like stress is something you can just, sleep over. A lot of people don't understand the implication of stress, to our physical health, especially. I've lost a couple of friends over the years that were stressed, and it affected them to the point that, yes, it actually took their lives. So I understand the impact and how stress can cause diseases that you will be wondering, where did this come from? So I would really want you
Absolutely.
to share more details on that in the chat room. So some of us who are under stress can begin to take it a step further and not just say, okay, I'll sleep over it, or I'll just take a stress pill and I'll get better. So that would be really helpful. Thank you so much, Dr. Faith. And then there's also much love for you in the chat. Saying hi and thank you, and we love you. Thank you so much.
Thank you. Thank you, everyone. I appreciate this, and let me just get my stop sharing.
Okay, so the next speaker will be a strategist in the house. He's Mr. Fisayo. Mr. Fisayo Kunsoya is a strategy, technical advisory, and capacity development professional with a background in management consulting. He's a graduate. Okay, Ricky, thank you so much, Ricky. Ricky, sorry. Okay, so I can see the babies also paying attention to this. Mr. Fisayo is a graduate of University of Lagos, Nigeria, who has over the years honed his skills and experience working with teams in the area of strategy and business planning, business performance management, human resources management, and project management. As a trainer, he has designed programs and facilitated strategy sessions for organizations across Nigeria, in Ghana, Kenya, Rwanda, the Netherlands, and Norway. Mr. Fisayo also led the team that designed and developed the Health Management Program, a business program for medical professionals promoted by Farm Access Foundation and the Enterprise Development Center of the Pan-African University, Lagos, Nigeria. He currently serves as a member of the faculty of the HMP, that's the Health Management Program. Over the years, Mr. Fisayo has served in executive management positions in different organizations. Until recently, he was the Business Development Director for the Medical Credit Fund, MCF, an international impact fund geared towards improving business position of health SMEs in Nigeria, Ghana, Kenya, Tanzania, Liberia, and Uganda. While at MCF, Mr. Fisayo led the team that structured and funded the acquisition and installation of an MRI and a CT scan at the 450-bed National Orthopedic Hospital Igbobi under a public-private partnership agreement. The installation of both machines changed the course of diagnosis at the hospital, leading to better overall outcomes. Mr. Fisayo was involved in providing technical assistance to Delta State contributory health commissions via the Access to Finance scheme in Delta State, where 15 abandoned health facilities were revitalized, handed over to the private sector, and are now providing care to about 100,000 enrollees under the Delta State Contributory Health Scheme. Mr. Fisayo is the author of the book, The Anatomy of Business, a practical guide to business planning in resource-restricted settings. He's currently the lead consultant at 6334 Group. He currently serves on the Human Capital Development Commission of the Nigerian Economic Summit Group. You're welcome here, Mr. Fisayo Okunsoya. We are really honored to have you in our midst. And Mr. Fisayo will be sharing on policies and strategies that can help mitigate the brain drain in Nigeria. Thank you so much, Mr. Fisayo. You're welcome. Please let's give Mr. Fisayo a round of a high five, virtual high five, and a virtual round of applause in the chat room. Thank you, Mr. Fisayo.
Thank you for having me. I'm really excited to be here, just for the opportunity to share some of these thoughts. Let me know if you're seeing the screen. If you are, then I can proceed with.
Yes, we can see your screen.
Thank you. So I'm going to be speaking from the policy angle and from the business of it, right? So as a strategist, one of the things that I bring to the table is a clear 2020 vision of the operating environment without the need to, sugarcoat or, just let's take a clear view and let's move towards what can be done to solve the problem at hand, right? All right, thank you so much. So here I go. Now, I want to set a context by talking about human capital flight, which is what we call brain drain. So human capital flight is the immigration and immigration of individuals who have received training at home. So you've received training in one place and then you go and apply your skills in some other place. Now, what you call brain drain, someone else calls brain gain. And you must understand that the world of work has evolved. Even though brain drain is not new, the world of work has evolved. And those that gain, the countries that gain the human capital, call it brain gain. Those other countries that lose, call it brain drain. The game is to ensure that your fingers, all fingers are not equal. Just ensure that your fingers are not the short one. And that takes planning strategy on a macro and a micro level. Brain drain is the loss of skilled, highly trained workers from developing countries to developed countries. So the idea is that these guys have been trained at a subsidy, and then they are now, and this is where the entitlement, I think, obviously creeps in, but they have been trained at a subsidy, and then they are now using that subsidy to ply their trade elsewhere. Now, Nigeria, obviously, the data is all there. We're experiencing high levels of brain drain, but it's not new. This happened in the 70s, early 80s. It's not new, right? So essentially, what we need to do is to decide. What we need to do is to decide where we want to be. If you look at the top 5 countries that benefit from Nigeria right now, they are Canada, the US, the UK, Saudi Arabia, and Australia. Those are the top 5 countries that benefit in terms of health workers from Nigeria. And you see their populations. Nigeria is second only to the US. So the idea is we need more doctors and nurses than these people, but they are taking the few that we have. And the question is, why are they taking it? So let's look at the aspirations of the health worker. What do health workers who just graduate from school, what do they want? 1, good working condition. 2, satisfaction. 3, good living conditions. Now, some of those things are within the purview of the health sector. Some of those things are outside the purview of the healthcare sector. But look at fit for purpose infrastructure. Most of the health facilities, even private in Nigeria, that are converted buildings, that are not a hospital. If you've ever gone to a hospital abroad and you see how it's done, it's now that a lot of the private facilities are now building, over the last 5-7 years, are now building like hospitals, right? Of course, the high-end hospitals have always adapted that, but most of the people that operate in Nigeria operate in a 2-bedroom flat or a 3-bedroom flat that was converted to, so it's almost like operating substandard medical conditions. Cutting-edge equipment, thankfully, Nigeria has a lot of that now, but it's not always been like that. Quality and continuous improvement and satisfactory pay, which is always debatable, given the level of inflation in the economy, decent accommodation, short commute to work, safe and secure environment, and then naturally a good quality of life. All these things are subjective, and they're subjective, which means that a good quality of life is defined by the person who owns the life. So this is the kind of life I want to live. And so you cannot use force or fiat, to define someone's quality of life or what a good quality of life should be. Right? So some hard facts about brain drain. Brain drain is not new. Like I said, people have always migrated to regions they felt were better for them, right? Brain drain is not peculiar to any discipline. Healthcare, banking, there was a time Canada was absorbing accountants, it's not peculiar. Brain drain is dynamic and cyclical. It will happen again in cycles. Multiple forces drive brain drain, many of which are beyond the control of healthcare sector. And we'll talk about some of those forces. And also, since COVID-19, the world of work has shrunk. Globalization has shrunk the world of work. Advanced countries are now attracting more health workers. This is because a lot of advanced countries lost their healthcare workers during globalization. A lot of advanced countries had a lot of healthcare workers resign during COVID. They resigned because they felt after the trauma of COVID, they just couldn't take it anymore. And then, of course, for the UK, Brexit, what Brexit did was that a lot of the guys who are EU citizens of other countries in the EU left the UK because they didn't feel at home anymore, especially the nurses. So you have this huge gap. Now, you said the UK is reducing the requirements for qualification, the US and Canada. These are all, and I want to pay attention to this, these are all strategic decisions taken by those governments to cover their health HRH gaps. They are all strategic decisions taken by the governments to cover their HRH gaps. The question is, what strategic decisions have we taken to cover our HRH gaps? Now, the best way government can use policy is not by force. And I think that we need to understand that doing things by force is not the only way, right? Because we've always driven policy by force in Nigeria, right? You have to stimulate a market that will naturally stimulate people to behave in a certain way. It's called determinism rather than fiat or force, right? Now, we move on and say Nigeria actually creates an environment for brain drain. Think about it. We have a tax-free economy, narrow tax net, with many citizens enjoying social benefits without paying tax. So you are looking at a tax to GDP ratio of 6% compared to the UK that we compare ourselves with, that has a 35% tax to GDP ratio, right? Then you are looking at subsidized medical education in Nigeria. It costs about $250,000 to train a doctor in the US, and they end up paying those student loans for years until the end of their residency. Even some of them as attendants, they are still paying, attending physicians, they are still paying those loans. But in Nigeria, it's relatively cheap. And if the government hikes it just a little, everybody goes on strike, right? Now, Nigeria has a youth bulge of 69% of the youth population, right? Unlike Europe and America that have 25% of their population as youth. And one of the reasons nobody says, everybody shouts that we have a youth bulge. But one of the reasons we have a youth bulge is that the death rate, the life expectancy rate is low, 54 years, 55 years. So people don't grow that old in Nigeria. That's the truth, you know? And so, of course, we always have a youth bulge, unlike Europe and America and Japan, where people life expectancy is 90. You know, all these things make it Nigeria a pool where, yes, brain drain works. And people look around and say, I want a better life for myself. I want a better life for my kids. I'm going to take what I can from this economy and I'm going to run with it, right? Some of the arguments you tell them, oh, you spend 40% of your income on tax. They'll tell you, yeah, but at least I'll have power. Do you know the trauma I go through driving home and wondering if there's light and looking at the streets and saying, is there light, you know? So these are things we need to consider, right? Now, this model, as complex as you just pay attention, is not complex. So you see there's short, medium, and long term, what happens with brain drain, right? So on the low income countries, we start with a bulge at the bottom of the triangle, where our young skilled workers drain into the developed world, which already starts with a narrower triangle. What ends at that point is that in the medium term, the bulge in the low-income countries becomes it flattens because we've lost a lot. And over time, the developed world now has a bulge on top, which are made up of our citizens, who you now start hearing things like, oh, a Nigerian did this amazing thing in medicine. A Nigerian did this amazing thing in this. A Nigerian did this amazing thing, you know? And because now they've learned from that system and they've grown and they've now become seniors, and that bulge, the developed world enjoys it. Now, what we need to do is that we need to put in policies that on the long term will flatten the bulge in the developed world and bring straighten out the triangle in our own world, right? Which is to say brain gain. How do we get people to come back to Nigeria? And that's what I think we need to start to discuss now, right? Now, the benefits of brain drain. Brain drain is not all bad, like the first speaker, Dr. Faith, said, right? It gives access to huge pool of skills. And I'll give you some case studies, how Nigeria has benefited, right? It benefits the health system and the economy, right? And then there's also repatriation, increase in remittances. So people who work abroad gain rare skills and then come back and they work here, right? If we give them the enabling environment, which we discuss about. According to the World Bank, funds remitted by Nigerians in the diaspora hit 65 billion between 2018 and 2020. And that's from people who live abroad. That's direct money coming back to the economy. So these, if you look at the spectrum of skill and funding, brain drain is not all that bad. But anything you do not measure, you cannot control, right? So we need to find ways to measure so that we can control and determine how to benefit from all this, right? So look at policy issues or policy considerations. A nation has comparative advantage at producing something if it can produce it at a lower cost than anybody else. Now think about it, right? A nation has comparative advantage at anything if it can produce it at a lower cost than producing it. Nigeria can deliberately deploy a strategy that leverages its comparative advantage with educating medical doctors. Nigeria can be the supplier of medical doctors and nurses to the world, right? And do it in such a way that our health system on the long run, medium and long-term benefits. How do we do that? We identify the core beneficiaries of our HRH, and we have already said it's Canada, the US, India, and Canada, the US, and all those places. Then we agree with them. We say, look, if you want to do this, then you need to build medical schools in my country, right? So you want to increase the production of doctors. Right now, total production of doctors in Nigeria is 3,000 doctors a year, right? I want to push that production to 30,000, all right? But I'm going to get people to come and build medical schools that will teach state-of-the-art knowledge here. Then I will set up endowment funds with a lot of the foundations here, a lot of the money that's going around that is aimless, which, right? Set up endowment funds. If EFCC recovers money from someone, you put it in an endowment fund. It becomes the money of the state. That's how other nations do it. You set up an endowment fund and you target only students that will not have gone to school. Now you kill two birds with a stone, right? You get students who will never have gone to school and you get them to become doctors, right? So you have brought in a critical mass of people into your medical programs, doctors, nurses, other cadres, radiologists, other cadres of health workers. Then you develop a system that allows the student to work and learn abroad and cycle, right? Now, I know they will cycle because nobody wants to live abroad in perpetuity. There's no place like home, especially given the weather differences. After people are exposed to the life abroad, they would enjoy coming back home, right? So you allow them cycle 5 years here, 5 years here. When you become a senior medical practitioner, decide where you want to settle, right? But all that while we have to be developing our internal environment, right? Improve your system and create incentives for them to return. Now, these are the issues that we need to develop. One, security. No matter how good it is to work in Nigeria, if I don't feel safe and my family doesn't feel safe, I'm out the next day, right? The other is demand side financing. Now, the thing about security, what people don't understand, the economic cost of security is so deep, right? The economic cost of security is so deep that we operate, I think at best in Nigeria right now, we operate a 6-hour economy, right? At best, in terms of efficiency, when other countries operate a 24-hour economy, right? We operate maximum 6 hours in terms of actual productivity because you don't feel safe. People want to get to work early, want to leave early. They don't feel safe. Especially look at this election period. Banks had to close early. That's the effect of insecurity, right? When you fix economic security, you can have primary care centers that run 24 hours that do not feel the need right? To have MOPO or mobile policemen guiding them or guarding them because they are safe. Then patients can be free, right? Now, regulation. The regulator in Nigeria is always playing catch up, and this is a problem. You have to have the brightest and the best minds in regulation so that the definition of quality is the same across board. I won't say beyond that. Then in terms of the fiscal space, you need to, and harsh economic environment, you need to fix the economic environment so that more people can pay. Look, everybody who has built a hospital today, what they will not tell you is that very few people can afford to pay for those services, right? Because the fiscal space in Nigeria is narrow. It is very narrow, right? Now, if you fix the economy, there are more people that can pay for those services. People always complain that our hospitals are small. If you go to India, India has 500-bed hospital, 1,000-bed hospital. I always tell them there are 300 million millionaires in India. There are 300 million millionaires in India, which means that, of course, they have space to pay for such services. Right now, even if you have 150 bed in Nigeria, half of the time, your bed occupancy is not more than 50% because people cannot afford to pay the service. Not now, not in this economic region, right? So these are the things we need to fix because any doctor that's coming back wants to ask himself, if I stay in the US, if I learn my craft, after a while, I'll be driving a nice Benz and I'll be doing well. How can your system help me so that it is, yeah? Right? Okay. Now, the next thing is sustainable, 2 ways of sustainably managing brain drain. One, improve conditions in the country and deploy HRA strategy. And I've already talked about that HRA strategy, right? So one is short-term, the other is long-term, right? Now, what can we do now? Like I said, produce more healthcare workers. We can become a net exporter of human resources. Resources are also something we can export. Improve production, right? Retention strategies, get people to stay, training, let them work with high-end medical equipment, good infrastructure, and then, of course, improve service conditions. Give doctors a tax break. If someone knows that if I become a doctor for the first 5 years, I don't pay tax, you increase the number of people who want to become doctors, right? You go to other countries, there's accommodation for doctors. When you say that policymakers always say, oh, if you do it for doctors, you have to do it for others. No, you look at the economies and the sectors that have a deficit and you do it for them because it's important, right? Now, this is a case study I brought here because it's been done, right? So the WHO prescribes recruitment of health workers between countries. And you can see the Philippines is a source country that already exchanges doctors with Canada, and they have a learn and return policy. Learn, then return. Learn, then return. They are exposed. India sources for Denmark, right? They have a learn and return policy. There's a whole WHO guideline that guides how people learn and return. So it's not something that's out of the world. You can actually tailor your human resources for health, and become, and look, the Indians use it as a domination play. And that's another conversation we can have, that they are everywhere. The Chinese also use it as a domination play. So if we are 200 million, then why can't we use a deliberate HRH strategy, right? The first case study I'll show you is Dr. Yemi Johnson, came into Nigeria in 2007, changed the way interventional cardiology is being done in Nigeria. Since then, we've had Dr. Kamal, we've had several interventional cardiologists come in. But I remember when he came, a heart attack was a death sentence. But now first cardiology has changed the way. This is after working in Charlotte, North Carolina for 20 years. He came and he now changed the way it is done. The second is Dr. Ahmed Ninolowo. Ahmed is a personal friend, fantastic guy. Now he has changed the way fibroids are being treated. He does fibroid embolization, vascular procedures in uracare, in first cardiology, right? These are things that, in fact, Ahmed worked on a friend that someone in the UK said it was impossible to do it in Nigeria. And he did it so amazingly. Rare conditions, embolizing fibroids. And this is brain gain, right? But these guys are working against all odds, right? There is a way that we can make it worth their while so that they don't work against all odds, right? So in conclusion, let me say that brain drain, brain gain depends on what side of the coin you're looking at. Nigeria can become a net exporter of healthcare workers to the world. We have the environment to achieve it. We need a clear process to drive the execution of a robust human resource for health strategy, and our health system and economy stands to benefit in the long run. And in the short run, we can now start looking at things like task shifting and task sharing, right, where lower cadres of healthcare workers can be trained, especially to do work in higher cadres under the supervision of those in the higher cadres. Because if you face the reality, let's take patent medicine vendors, for instance. There are local governments in this country where there's no community pharmacists, none at all, none. The first point of care is a PPMV or a patent medicine vendor. You know, why deceive ourselves and say, oh, it must be a community vendor? Let's not deceive ourselves, right? Let's not deceive ourselves. Let's release them and let the community pharmacists supervise them, right? Let them supervise them and get things done so that people stop dying, right? Thank you so much for having me. I'll be around to take any questions if you have any. Thank you so much.
Thank you so much, Mr. Fisayo. That was an incredible presentation. Thank you. Thank you as well for helping us see that, you know, brain drain is not just a negative thing. It actually has a lot of positives. So yeah, we really appreciate that time. I think a couple of key things for all of us was just how you put it in perspective to help us see short-term solutions and long-term solutions, you know, how we can begin to work on the current environment, the working conditions, the living conditions to make it and even, you know, make Nigeria an even more attractive place. And then long-term, you know, this whole idea of how Nigeria can really be a training ground and how we can export our doctors, because really that's what's happening, and how we can do it in a way that benefits us even more, in a more structured way. Absolutely great and a really good way to put it. Thank you so much. One of the things that is really key to us at Pistis Foundation is to be able to influence policy, not just to be able to, not just so beyond these conversations, we want to be able to say, how can we create impact that would affect what's going on in the country? And we intend to put together some form of communique from this session, especially from this session and from the whole webinar, and to share with government to see what we can begin to do. And, you know, by the grace of God, we'll be able to make a more holistic impact. So thank you so much for that. Please, let's put our hands together for Mr. Fisayo for that brilliant presentation. Let's thank him in the chat or by putting a reaction in on our, just above our faces on the, thank you so much.
Thank you so much, Mr. Fisayo. Thank you very much.
So moving on to the final speaker for today, I want to, just before I move on, I want to especially all of the medical. I know that there are a lot of medical professionals here. We appreciate you. We thank you for all that you do, all that you've done, either whilst you were here and before you left. But I know that for some professionals, you're interested in the opportunities that are available abroad to grow, to develop yourselves, and hopefully to become future brain gain for us in Nigeria. So we have invited Dr. John because we think it's important for you to have a holistic perspective of what it really entails to be a doctor abroad. So he's going to be talking to us about the realities of healthcare work. So whether that's as a doctor, as a nurse, or whatever form of healthcare work abroad. Dr. John earned his medical degree from the College of Medicine, University of Ibadan, Nigeria, and he went on to do his housemanship at Omotayo Hospital, Ikeja, before then moving on to complete his internal medicine residency at Columbia University, Harlem Hospital, New York, and a fellowship as well in infectious disease at Louisiana State University in New Orleans. Dr. Nadi is a fellow of the Infectious Disease Society of America and the American College of Physicians. He's board certified in internal medicine and infectious disease. He practiced infectious disease. He currently practices infectious disease at Oakney Medical Center in Louisiana, USA. Please join me as we give a virtual hand clap to Dr. John as he takes over, and as Mr. Fisayo puts down his screen so that Mr. John can take over sharing. Please let's put our hands together for Brilliant. Let's put our hands together for Dr. John Nadi as he takes over.
Okay, thank you so much, Louis. I just wanted to mention that if you're dropping your questions in the chat room, we might miss them. So please drop your questions in the question and answer room so that we don't miss any of your questions, because I'm scrolling through the chat room and I'm seeing lots of questions in between there. We might miss your questions if you drop them there. So it's preferably you drop your questions in the question and answer room so that we'll be able to capture each of your questions and answer them when due. So the chat room is just for high fives, exchanging pleasantries, and sending out love to the speakers. The question should be in the question and answer room, please.
Thank you.
Hello, good afternoon, everyone. Can you all hear me?
Yes, we can, Dr.
Yes,
John.
good afternoon.
Hey, good afternoon. You can see me too. So I'm talking about working as a physician outside Nigeria. For most of us who were in Nigeria, our dream was to go somewhere where we could practice, of course, get a better quality of life and things like that. I actually was in the Caribbean before I came to America. So I also have experience working in a so-called third world country, but better developed healthcare than we have. I was in Trinidad, I was in Grenada. So why brain drain? People do brain drain because for obvious reasons, as was said before, we want to have better quality of life, better job, better technology. And we understand that. But what we found out was that once we start here, by the time we reach here, we notice that it's not always what we thought. So hold on one second. It's not just what we thought. We found out that in the Western world, things are really different. Like to do internship here, then the rules have changed now. We used to work approximately 120 hours a week. I used to think it was a joke until I did it. It was crazy. At that time, sometimes you get to work by, say, 5 in the morning, one day, so on one particular Friday, you might not leave till next day by 12 or 1 p.m. The rules have changed now, though. The government made a rule that you can't work more than 80 hours. But it was a tough experience, but we learned. I remember those days, a number of the physicians that came from Africa in my program then, we actually most of the females going home crying, but it was that tough. Next thing we discovered was that, I know was mentioned also by Mr. Fisayo, the nurses here have more autonomy. You can actually get your master's and become a nurse practitioner in which you can manage like local healthcare center on your own. Sometimes with a doctor supervising or sometimes on your own. I'm saying this because that could be another way that could help our doctors become less stressed out. So here you have, because there's so much demand for primary healthcare and we can't meet up. So they train nurses to actually encourage them to, after they finish, some of them get their masters and they can be a little bit independent. They might have a doctor overseas, they might have one doctor that might have like 5 nurse practitioners working under them, and they can do primary basic healthcare, blood pressure, diabetic control, things like that. The next thing that was an eye-opener for us was how much control insurance companies can have over what you do. Take, for instance, somebody comes and you put an order for a CT scan. It has to get approved. Somebody might say, well, I don't think they need a CT scan for A and B reason. Now, these are not always doctors saying this. If you disagree, you could have a meeting peer-to-peer with them and make your case. In the UK, it's a little bit different because the UK has a focus on primary care. So the rules are a little bit different in the UK. UK, before you do basic tests first, before you do the more expensive ones. In America, it's different. You can order anything. It just takes if you can justify the need. Of course, litigation. Here, yes, patients can sue for little things. People always have to, and that's partly why doctors tend to do a lot more than they should, because If you miss something, yeah, they can sue you. And they do. The next thing we will noted here was that all the records, I know Nigerians are doing it now, are electronic. So if some of us who trained many years ago that didn't learn so much how to type, kind of struggled to type faster. We got it. Some people say struggle, like the older doctors who came from Nigeria struggle to type, but it's a system. You all have to type many things, no handwritten notes, no files that goes around. It's all being typed. I will mention the Cures Act in the next slide, and I will talk more about it. The next eye-opener was that antibiotics needs prescription. You can't come and say, oh, I'm feeling sick. Can I have medication? Oh, no, you have to see somebody. It has to be prescribed. Go to a pharmacist. So a pharmacist cannot just give you antibiotics. It has to be prescribed. Again, to specialize. So you might have a dream that you want to be a surgeon, ophthalmology, dermatology. It doesn't work so. They tend to leave some sectors for American trained doctors. You can still get in, but it's a lot more difficult. Most foreign medical doctors tend to match in internal medicine, family medicine, and pediatrics. Let me mention some specific laws that are very unique here. HIPAA law. Now, most of us have this to an extent, even in Nigeria, that you have to be careful about patient privacy, but they take it very seriously here. Like, take for instance, if they ever find that like a record of a patient is thrown outside your house by mistake, the fines are a lot. Or you go into somebody's chart, even a family member's chart, and it's reported, it can be a big deal. I know, of course, if it's a very prominent person, it's even more serious. When Bill Clinton was sick at a stage, he was in a place I work in one of their little hospitals. Some doctors went to his chart and nurses, they were all fired. But there's a tracking system. So once you log in, one knows that you log into his chart. They fire them. Again, so there's the huge fines for doing that. There's an interesting law that they have here, which I'm happy Nigeria is starting that. So this EMTALA law means that if you have any serious medical condition, the commonest one is a woman in child labor. No emergency room can deny you care. If you have a stab wound, you have an accident, they don't have to ask you to drop money first. It doesn't matter how much money you have. You come in, get stabilized, and then we could start talking about money. I was told that this has been implemented also in Nigeria. This is very helpful. So it means that you should not be afraid. Like if you come in and you need to go and see someone in the emergency room, you can at least go there, get stabilized, not when they will ask you to drop some millions before you get seen, which is a good thing that we learned. And the violations and the fines for violating this law are huge. It's not just for the hospital, it's also for the doctors, the individual physicians who did it. So you could pay as much as 25 to 50,000, and the doctors can pay a lot too. Even another one is that, take for instance, I come to a hospital and you call the surgeon and they don't want to come out and they are transferred somewhere else. And that other hospital knows that, oh, that surgeon was on call, but didn't call him, they will fine them too. Huge fines. Let me talk a bit about the Cures Act. This came out like this last year. It's an interesting law. The summary of law is there is that every patient can read their notes. So as you're talking to a patient today, after you finish that discussion in 5 minutes, they could log in on their phones and they will see everything you wrote about them. I have had patients call and say, oh, Dr. John, you said that I have headache, but you also did not mention that I also have leg pain. They could read all the symptoms you wrote, every single thing you wrote. That means you have to also be careful what you write. In the past, sometimes doctors can write things that other doctors can see and understand. But now, no, they can read their notes. This goes also for the nurses too. When nurses write notes, the doctors can see it the patients can see it in real time. So you have to be careful what you write. Again, we mentioned it before about how brain drain can be a brain gain. One thing I want to mention that exploded post-COVID is role of telemedicine, even in America today. So some hospitals are in rural areas of the country and we can't get to them. One standard one that has been on for so long is stroke. So if somebody has any symptom of stroke anywhere in this country, most emergency rooms, they don't have to have a neurologist. They have like a computer screen, like Zoom as we're talking now. They just activate, they call it a code stroke, a stroke team, and they affiliate with somebody who is a neurologist that will determine what to do. The commonest thing we tend to do, like if you see an acute stroke within 4 hours, is to give a clot buster if they meet the criteria. And that can be done. They've expanded this technology to almost any specialty. I can stay here I am and advise on the right antibiotics anywhere in the world. Even in Nigeria, you could have a Nigerian hospital who can get doctors abroad that can help with cases. I know, for instance, like John Hopkins does that for some cases in Africa. Even they can have grand rounds, because part of what is also important is training medical students, training them with the latest technology, the latest thing, so we could support each other back home with this. The next thing I also want to mention is about empathy for doctors. There is a grading system that we have that doctors are surveyed and graded. People complain sometimes that nurses, doctors sometimes are not very empathic. I had bad experience with this in our training ourselves. We had to deliver babies. We call it catching babies when we're in training. I won't mention the name of the hospital, but in the place in Ibadan then, it was a horrible experience. The way they were treating those women in labor was horrible. And it was mostly done by the nursing staff. Now I understand, sometimes they are very stressed out. You can't have an overstressed doctor or nurse and expect them to give their best. However, here, after you do that, the patient will go to a website sent by the hospital, and they will write about the experience. It can affect your grade. It can even affect the amount of money you get from the government. So they take it very seriously. I actually sit in committees that review this sometimes. Like for, say, infection control. Like if you come into, like I monitor, for instance, hand washing. So we have what they call secret shoppers that see who washes their hands when they go to see patients. And we review the data and we can say, oh, this person or this unit didn't do it. So because of that, people are conscious of what they do. They know that if I don't do this well, I can be monitored, I can be graded, I can have a bad rating, and it will affect you and the entire hospital. We'll have questions to answer at the end. That's all I have. Thank you.
Thank you so much, Dr. John. Thank you so much. We really, really enjoy your session. Can you all hear me, please? I want to be sure everyone can hear me.
Yes, we can hear you.
Yes, we can.
Thank you so much, Dr. John. It was really an insightful session. Please, let's give Dr. John a round of applause in the chat room. Let's appreciate Dr. John for this session. I know that if he had had more time, he probably would have, delved in deeper. There are obviously a lot of healthcare professionals I can see in the chat room. Everybody's concerned about this topic and how we can move forward. It's obvious that health issues are very, very critical to us Nigerians. Thank you so much, Dr. John. I think one of the things that struck me, one of the things that struck me most is the telemedicine idea that you raised. I know that there are a lot of organizations that have tried to do something similar here in Nigeria. I know. But however, I think the challenge has always been with funding those kind of projects, you know, remunerating the doctors. I don't know. I'm just curious to know if you've had, maybe during the question and answer session, you know, you share more light on telemedicine, and if you've had any experience with how it works in Nigeria and how we can improve on it, especially for private organizations who want to invest in that. Sorry, there's an echo. Okay, thank you so much. So I think we have a lot of questions in the chat room. So if you have dropped your question in the chat room, please, I would appreciate if you could copy the question or send it again to the question and answer room. That way we'll have clear access to your questions and be able to read them out clearly and click, as long as anyone will answer will click on it. So if you know that you haven't typed in your question in the question and answer room, please just do us the favor of typing it in there so that it's organized and we can see it clearly. We have some questions that have been sent earlier. I will just go ahead to read some of the questions that are targeted towards specific speakers, and then we'll get to see how many questions we can answer before our time is up. We have about 30 minutes more, I think, to the end of this webinar. So I'll just go straight ahead to the first question, which is for Dr. Faith. So Dr. Faith, thank you so much again for sharing on some tips and strategies to which we can help to maintain our health. And I know that you shared a lot of tips around patients, how patients can help to maintain their health, especially during this period of brain drain. I know you also mentioned some tips to healthcare professionals too. However, I want you to just shed more light on some of the things that current healthcare professionals that are still actively working in Nigeria, those that haven't left and are not thinking to leave anytime soon. How can we go a step? How can we take a step further to help to mitigate the outcomes of this brain drain in Nigeria? How can we help our patients actively? You know, I know that yes, we help our patients in the hospital and everything, we do our jobs and get out, but how can we go a step further to mitigate some of these health challenges so that we will have less mortality as a result of brain drain? Dr. Faith, I don't know if you can hear me.
Yes, I can. I can hear you.
Thank you so much, Dr.
Okay. Thank you very much. Thank you for the question. I had mentioned a bit of that earlier on in the presentation about what we could do as clinicians on ground to actually mitigate the impact of the brain drain and ensure that our patients have access to care that they can actually value. Now, one of that is, I mentioned holistic care when attending to a patient, to look beyond just what the patient is coming in for, beyond making a diagnosis and treating the diagnosis, to actually see the patient as a whole and be able to look beyond the immediate complaints to addressing probably things that are probably not obvious or overt. And having that sort of holistic mindset will help us to actually be a bit more preventive in the way we deal with our patients. For instance, a patient comes in and is talking, he says he suffers from migraine, and from another hospital, the doctor just gave him migraine tablets, and then he keeps going in and out, and they keep treating him for migraine. But then he talked about his blood pressure being slightly up sometimes and slightly down. By the time it comes to my practice, what we did was we decided, talked with this patient, took a bit more history, and decided, I think we need to do an ambulatory BP monitoring for this patient, because this patient actually fits the category based on the history. And at the end of it, we found out that this patient was actually had come just beyond pre-hypertensive and at the point where he needed some intervention. And that will not be picked up easily just by a one-off attendance. That's just an example of some of the things we can do. And I mentioned earlier on, as clinicians, becoming, having a sense of responsibility in terms of health education, owning it in our social media space, in our churches, wherever we find ourselves, to get involved in health education, use the media to educate. I remember during the COVID, actually, I sat down one day and I was thinking about the impact of the COVID in Nigeria, and thinking of all the things we had to do and the UK government was doing for us to ensure that we were able to cope with the COVID pandemic. And then I thought about Nigeria and realizing that they might not have the same things. I sat down and just did a short video, and it was just meant to encourage the people within my network on Facebook. Finally, that video actually went so far and went viral. So if we all have that sense of responsibility who are on ground, then we can actually do a lot more. Another area we can actually get involved in is using the little we have to reach a lot more people. Telemedicine is one very important thing. My practice, Reddington Hospital, we use telemedicine to our advantage. And I'll give you an example. We have a prof, Professor Kweme, who comes into the country at the moment, and he does laparoscopic neurosurgeries. And what we've done basically is have a pool of patients waiting for him. He does telemedicine with them, finds out the initial consultations. And then when he comes in, he gets on ground. He's able to do a lot more, and then the surgeries happen. Now, that's one that as clinicians, we can actually leverage on the expertise from abroad. Those of us who have PAJAD can do that. And then another thing I started doing since coming back is actually organizing clinical meetings, training my younger colleagues and even the rest of us, clinical meetings, grand rounds, and inviting our colleagues from the diaspora to be part of what we do. And that has gone a long way in actually promoting the growth in knowledge and expertise. And so there's an exchange of skills and knowledge. And then there's the inter-hospital partnership that can actually help. Recently, we got together in accidental and emergency, and we realized that I have 8 ambulances, you have 10, you have 5, that if we all come together and we pull up our ambulance resources, we can actually be able to have a wider coverage, reach a lot more people by building a network online where we can all communicate and have an interface. And that's something we're currently working on, a partnership between Reddington and some other hospitals to make sure that we reach a lot more people with timely emergency care. Thank you very much. I hope that answers your question.
It's actually, I'm so excited to hear some of the things you're currently doing. It shows that and there's hope, there's light at the end of the tunnel, and I'm really, really excited. Thank you so much, Dr. Faith, for sharing and for shedding some light. If you have any questions for Dr. Faith, any other questions, please you could drop them in the question and answer room, and we'll get to them as soon as possible. Mr. Fisayo, are you still here? We have a question for you, please. Your session was very, I think it brought back some good memories, because when you were talking about some of the benefits of working as a healthcare professional in Nigeria, it took me back memory lane to when I was a child. My dad had this brand new 504. I don't know how many people studied the medicine or pharmacy during that time. Yes, my dad was a pharmacist, and when you I don't know if you remember then. I don't know if you.
Yeah, I do.
My dad, when he graduated from pharmacy school, there was a brand new 504 waiting for him.
Yeah.
I remember being driven around in that 504, and I was really was good.
Proud.
Good feeling. I can't believe that we are in this time after how many years, and this is the stage where we are. However, we have to see how we can get out of it. So someone is asking Mr. Fisayo, do you think the proposed bill will bring respite to the brain drain, given the critical basic issues are not being addressed by the government, especially in areas of health planning, strategy, and forecasting. What do you think? How do you think people will react to this proposed bill of the government that has passed the second reading?
Thank you for this question. I think the answer is clear to everyone that people will react in rebellion to it. You cannot use fiat or force to shape culture. You can't. You cannot determine culture by force. There are many ways, moral suasion, many different things you can do, but you cannot force people. You cannot force a way of life on any set of people, right? So what will happen is a lot more people will seek to do their undergraduate studies abroad. Admission into medical programs will drop. People will find a way to game the system. The bill will create, or the law, if it becomes law, will create another opportunity for corruption where people will get exemptions to travel
Indeed.
after they've completed their system. You cannot use fiat to shape culture. You have to take responsibility, right? And the things I've already said are the ways that you can take responsibility. Let's start talking about increasing production. Okay, so the question someone asked me a while ago when this bill first came out was, does it affect those in private universities? How about those who have sent their children to Babcock?
Indeed.
Right? And have paid a lot of money. Are you now going to say they should? So if it doesn't affect them, then you have created an inequality. Because we both start medical school and it takes me, and so people will look for money and go to the Babcock instead.
Indeed.
You see, so you need to think through policies. And I said it, I didn't want to say too much of it, but policymakers are always playing catch up in Nigeria. It's one of the major problems we have. They are always playing catch up. We have policies that enter into the space that are not thought through and that are knee-jerk reactions based on people's egos. What is the problem? How can we solve the problem? The problem is with the system. You can't have a fiat solution to a systemic problem. So I think we all know the answer to that. It's not going to solve anything.
Thank you.
It's going to create further dichotomy within the system. And it's going to shatter and break the system even further.
Yeah.
Indeed. Indeed, Mr. Fisayo, thank you so much for opening our eyes to some of those half-baked policies. Thank you so much, Mr. Fisayo. I'm just hoping that at the end of the day, we'll be able to send some of this in our communique to those that can actually influence some change in terms of policies. Dr. John, is Dr. John still here? Can you hear me?
I'm here.
Thank you so very much, Dr. John. So my next question is actually for you. I think a lot of people are wondering, despite all that is going on and with your experience on the field and internationally, how do you think universal health care can be achieved in Nigeria? How do you think is it possible for us to achieve it? And how can we, what can we start doing to achieve universal health care in Nigeria?
I think it's possible, at least the primary basic health care. I remember when I was quite younger, Ransom Kuti, I remember then, my mother was a nurse. I remember when it was announced then, when I was still in secondary school, about the primary care initiative he has. We can focus on basic preventive primary care. We have the money for it. We can afford it. And it doesn't all have to be doctors. We can train people. Nurses can be trained like they do here, maybe give them like extra training to be able to staff and manage rural health centers. Because it's mostly blood pressure, it's mostly malaria, some type of basic. These are basic stuff. They can.
True. That's looking at it in terms of when government wants to sponsor or like you said, they are in
Government and private care. We can't all rely on the government. You know, our government is not very
Yeah, that's it.
private people. Like,
That's it.
so many examples. Because remember, at the end of the day, like one of my friends, for instance, told me this, that part of his job was he works for an oil company and the healthcare sector. And he was telling them, instead of giving us money to send all our executives to these expensive hospitals, can we go to help some of them develop? We can work with private healthcare sectors, like all this, they have the funds too. Give them tax breaks. So like if you are going to fund this, you get tax breaks, MTN, all of you can do that.
If I may just add to what Dr. John has said, if it's okay.
It's okay, Dr. Faye. Thank you so much.
I still remember as a child, we used to have these health inspectors who used to come around and just look at the environment and penalize people who don't keep the environment neat. And I still remember, not even as a child, but just a few years back, environmental sanitation. Where have all that? Sorry, thank you. I stopped my video. You know, you wonder where all that has gone. So when he was talking about prevention, focusing on prevention, I think that's very important. We have to, as a community of people, focus on prevention more than anything else. And then I just want to point out this, in the NHS at a point during the COVID and post-COVID, because they were not able, because of the Brexit, and they were not getting the right numbers of clinicians, and they started training what they call physician assistants, people who worked as doctors, but with limited capacity to do certain things, but who could actually see patients alongside doctors and come to us and ask questions. We will do the prescriptions and cross-check what they have done. What that meant for us in the A&E, for instance, is that our waiting times came down because these physician assistants will be able to see the patients, clock them in, and be able to do some of the initial investigations and come to us for support in making the final diagnosis and do the treatment. I think we need to come to terms with the reality and begin to develop such things. Physician assistants, nursing assistants, begin to train them, and training is so key. And that's an area I'm very passionate about, and I think we need to focus on that at this point in time. Thank you.
Thank you so much, Dr. Faith.
Thank you, Dr. Faith.
Sorry, I'd like to say something, if I could, about universal health coverage and whether Nigeria can achieve it.
Okay, please go ahead, Mr. Fisaya. And please, if you can just increase the volume of your voice so that we're good.
Universal health coverage and whether Nigeria could achieve it. Now, because I also saw a question about how the poor can pay for health insurance, right? Now, Nigeria has a system that's quite different. So social health insurance cannot work in Nigeria's current form, right? For three reasons. The three core pillars of social health insurance are: one, employee and employer contribution, right? We have an 80% informal sector, so you're not going to find that. So it's tough, right? That's why the NHIS didn't work. The second thing is tax, right? So the government pays a lot of that, right? We have a tax to GDP ratio of 6%. The UK has tax to GDP ratio of between 35 and 41% sometimes. You know, so they collect enough of the tax on the value created in their country to be able to fund the healthcare sector, but we cannot do that. So we need to reframe the informal sector, because a lot of our value is in the informal sector. So we need to reframe how we relate with the informal sector so that we can get value from them. The third pillar is that the product that you are selling in a social health insurance system must work, right? For people to, even if you can use policy and force, because our health insurance is now mandatory. Even if you can use policy and force to get people to pay this year, if they get to the PHC and they find the quality that's out there that they don't even want to send their dogs to be treated there, then they will not pay next year, you know? So you have to face, like I said, face reality. On those three pillars, Nigeria is failing in its society. So social health insurance cannot work. So we know what we need to fix. We need to fix our primary healthcare system, right? Now, there are ways to fix the primary, like we said, we did something in Delta that works. By the way, the program that we implemented with the Delta State Health Insurance Scheme, maternal mortality ratio, after 2 years or 3 years of running, it was 0%. I kid you not. It's out there, the research is out there, it's online. 0. Because the issue that drives maternal mortality in Nigeria, and I don't mean maternal mortality in the whole of Delta State, among the 15 PHCs that were handed over to private sector. Why? Because the issues that drive maternal mortality are negligence, culture, so many things. We found women who will give birth and go missing for 8 days because that's what the culture dictates, and they die. We found 17-year-old boys coming for circumcision because the guy who used to do it 17 years ago were killing their children and the women refused to send their children. We found a woman who came to the clinic and she said she was pregnant for 8 years with a demon. It was multiple fibroids. Look, this thing can be done. It's painfully simple, but we just need to face the root causes. Why, right? Now, in terms of health insurance, there are many ways of domestic resource mobilization, right, that are sustainable. I'll give you an example. The Dutch government of Netherlands, for instance, funds its health insurance scheme. They have one of the deepest health insurance schemes in the world. I mean, imagine a health insurance scheme that covers complex cancers end to end, right? It's very fantastic. But how did they get that deep? They ensure that 50% of the Dutch lottery system, the proceeds go into health insurance. That's amazing. So imagine you say everybody that's playing Baba Jebo and everybody that's betting, 50% of the proceeds go directly to health insurance. Then governments also use things like sin tax. Sin tax is tax for sugars. The UK does sin tax a lot. In fact, the UK government, it's just that they don't devote it solely to health, made about £9 billion from sin tax over the last 2 years, right? So you tax sugars, you tax tobaccos. If you're going to smoke, smoke, but you will pay for everybody's health that you're putting, right? So if you go to Amsterdam, everything is legal, but expensive. And the sin tax is used to pay partly for healthcare. These things are being done all over the world, and they're simple to implement. What we need is the political will and the seriousness. Thank you very much.
Thank you so much, Mr. Fisayo. I think someone is asking, I don't know, Mr. Fisayo, I don't know if you would want to just go ahead, because someone is asking, I think your passion is moving people to ask some very personal questions, like, have you been able to share some of these, your thoughts, and some of this, your insights with anyone in policy, any policymaker or anyone? I think someone is curious to know how far you've taken some of these, your strategies and...
Okay, so I'm going to repeat the last comment.
Yes.
And use it as an answer. What we need is the political will. Do you understand what I'm saying? People need to be willing to make this happen. For us to have implemented it in Delta State with farm access, and you know we have already engaged governments on this, right? And Delta State was willing, and it happened. I mean, I wish they need to run it as a case study. We had clinics in places like Olobubo, Okporosa, right? Places that are 2.5 hours off the coast of Warri, south. Places that you require a speedboat. So when a place is 2.5 hours, and just to get to the speedboat to land is 40,000 naira, how do you expect women not to die in that community? Do you understand what I'm saying? So what we did was we took a guy from Oka, private hospital from Oka, I won't mention his name. He went and ran the place. Chevron donated the hospital. It was abandoned for 10 years. The guy from Oka went and ran the place until today, running it profitably. Because if you fix health insurance funnels money into the health system. That's where the US thrives. right? The US health insurance can pay you only 20% of your fees, but they will load you with patients, right? So even if your money is supposed to be 20,000 and you say it's 5,000, but instead of doing one in 2 days, you will do 20 in 1 day. You know, in the end, the doctor will still drive his Mercedes now. And the guy is happy. He's tired, but he's happy. You know, so that's it. Health insurance causes efficiency. And so the Delta State Health Insurance has, by now, they should be nearing 1 million enrollees. You know, so they were able to put that within their system, subsidize it, and get it to work. That community has 50,000 people. One community, water, riverine community. It's been done. We've engaged policy people on it. Again, what made it work in Delta was we had someone in Dr. Ben, who was the head of the health insurance agency, who was willing, had the political will and the backing, and he wanted to make it work. Until you have leaders in the policy space who want to make it work, it's not going to work.
Thank you so much, Mr. Fisayo. I think we'll have one more questions for each of the speakers, and then we'll probably take the questions home and answer them later, because I'm not sure we'll be able to answer all the questions in the chat room. So I have one question for Dr. Faith. I think this will be your I'll see if I can merge two questions together so that we'll make it easier. Dr. Faith, someone is asking, in continuation to what Mr. Fisayo was talking about health insurance, it's a big challenge, and which we have to overcome for clients to enroll. So how can low-income earners afford premium insurance? I know you understand what I mean, because some of these premium hospitals would not even want to engage with some of the HMOs that are currently running, you know, for one reason or the other. So, but how can low-income earners truly afford premium insurance?
Okay, thank you very much for that question.
Yeah.
I guess say at the moment for low-income earners, the government is actually, at least Lagos State government at the moment, is actually intervening to ensure that every hospital takes on some of the burden of the NHIA scheme. And so the onus is now left to you as an organization to decide how you're going to manage it. I know it's something we're currently dealing with because they've gone beyond, so it's no longer a matter of NHIA is restricted to the hospitals in Ikotun and Idimo. No, the government, Lagos State government has made it such that every hospital in Lagos must take a chunk of that NHIA subscription. And we as a private sector, our job is to sit down and decide how we're going to dispense that care in a way that is appropriate, meeting the needs of the patients who enroll, and at the same time meet the cost of service that we offer. Now that's a tough call for us, but like Mr. Fisayo has said, it's a bit of ruling by fiat, but we are taking it on. So that's that. But for every other person, that is the middle income, and I think that at the moment there is health insurance in Lagos I can talk about. It's quite robust, and there are different levels, and you could actually find one that is appropriate to what you can afford. And the benefits are huge. One of it is that you don't have to concern yourself about the financials if you do need to access care. And I've seen it work quite significantly. So there's so many of them out there in the healthcare space. There are HMOs who just deal on capitations to the healthcare organizations, but are able to enroll as many people into their HMO care. So I think there's something at the moment in Lagos State I can talk about for everyone. In the long term, I will think the government alone, this is what I see happening, is going to be an evolving between a public-private partnership until the government is able to actually do what it's supposed to do. But I see it evolving, and it's slow, but things are gradually happening. And to ensure that every Nigerian is able to access care. It's slow, but I see it getting to the point where the government takes full responsibility, and we're hoping and praying that happens. But I won't fail to mention the huge impact that churches and other non-profit organizations are playing at the moment in ensuring that healthcare, basic healthcare is given to Nigerians. That's one way to go. And there's so many organizations and religious organizations in that space. And I think PC's Foundation is one of them. And thankfully so. Thank you.
Thank you so much, Dr. Faith. I think you answered two questions in one. I don't know if you saw the question ahead, but it was someone was asking for the long-term outlook, and you actually dived into that. Thank you so much.
Yeah.
Dr. John, we have some questions for you. I'll try and see if I can merge them too. One of them is asking someone wants to hear your opinion about the solution to brain draining in collaboration, or rather, which in relation to what Mr. Fisaya has spoken about. Ultimately, they're curious to find out what kind of enabling environment would you want to return to if you were to return to practice in Nigeria? What kind of enabling environment are you looking forward to? Especially interested in the impact of family and other roots that have grown in foreign countries and the ease of return, exactly. So what will make it more comfortable for you to return periodically to come and practice in Nigeria? What will make it more comfortable for you to set up a practice in Nigeria comfortably? So people are curious to find out.
Okay, and I'll answer two questions in one, because somebody else asked about telemedicine. The difficulty with moving is like with the children, they're in school. So it's hard to set up a practice, mostly for internal medicine. Like surgeons can maybe go for some time, work, do things, and come down. For us, internal medicine is a little bit more difficult to sustain it that way. One area I see is that people can do medicine from here. Like, let me give an example. Evercare Hospital in Lekki, there's a group I belong to here that partnered with them, and they send us some of the cases. Okay, they have a difficult case, they send it to us, and we review. Like, I am internal medicine, for instance. I'm also ID. They have like difficult, some with fever, they can't understand what's going on. They have some culture. So I review the culture, some of them, and I give advice. And just write, want to do other A, B, C, D, and that. And that can happen with internal medicine, at least. So you could have doctors in UK, Canada, abroad, who can help review some of these cases and work with the local doctors. Relocating your whole family abroad is challenging. You could go for maybe a month, or when you're on vacation or health mission, but it's difficult because of children. Because as you get older, you have ties. It's hard to move.
Indeed, Dr. John, we actually understand. You went to something about telemedicine. I don't know if you meant, because that's what you're talking about.
Yeah, so like you can see how we're having this session right now. Imagine there are 10 patients to see. So we can review that will involve the hospital having like a chart that is also electronic. So we can review the chart. See, like I can see your note, like you came in last night, I can see the note, I can see your lab results, I can see the cultures, and then we can truly talk with the patient on video and document. Okay, right, I saw this chart. Why don't we do A, B, and C? And then you discuss it with the doctors there. I will tell you right now, as I'm talking to you, this is becoming very common, even in America.
Indeed.
Yeah, there are rural areas that don't have doctors. They are using this, what I just said now, to run their practice.
Okay. Okay. Dr. Faith,
Sorry, Dr. John.
Sorry if I
Even Dr. John, even in Nigeria,
yes, I know they have it in Nigeria too.
we are using it very effectively because there's a huge scarcity of radiologists
yeah.
and radiographers. And so you are right. If we can use it that where people scan and then you send the scans to
Precisely.
be, then it can be done.
You know, if
You're right, it can be done.
let me tell you, where I work, for instance, our night is morning in India. So we send some prelims, I'm serious, some prelim scans to India for fast reading, some of them.
Wow.
The next morning, doctors here with different time zone can now sign off on it. But if you want like a start results right now, because when you're sleeping, Indians are awake. Some of them can read that.
And that's efficiency,
I just want to bring in some balance. Telemedicine is amazing, but as good as it is, we have to streamline it to the areas where we can use them. For radiology is fantastic. Reddington Hospital, we use Accurate, and that's a team of radiologists who report all our images. And what that means is that it's almost zero, there's zero mistakes. So you get, and then you get it on time. Now that's radiology. We've also, we've done telemedicine. But one of the things we do in Reddington, for instance, is continuous quality improvement. And what that means, you audit your processes. You take a look at it. Is it working? And what that means is that you have to interface with the users. And we found out that there are certain specialties where the patients don't just want to be seen virtually alone. Maybe after 1 or 2 sessions, they do want to physically see the doctor. They want to be physically examined. And there is something, there's an article in the British Medical Journal about the power of touch. That is something telemedicine can never give to you. And we have to understand that is a huge part of the practice of medicine. Your ability to be able to touch your patients, examine them. So yes, we can use it for certain things, but we have to be careful about what we use it for and what we don't use it for. Thank you.
I agree completely. I agree.
Thank you so very much. Thank you so much, Dr. Faye. Thank you so much, Dr. John. And then finally, Mr. Fisayo, we have one question for you before we round up. I'll call on Louis to round up after you answer the question. So some people are concerned, some of the policies that Dr. John suggested around some of those interesting policies that are work abroad that we're trying to enforce here in Nigeria, some of them we haven't even tried. But some people are wondering, how do we enforce it among hospitals? Some hospitals don't care. Some hospitals don't care. They're like, okay, whatever. You know, people don't really, enforcing things around here is an issue. You know, so I don't know if you've had any experience with enforcing some of these laws, and how did it go? How was it? How effective was it? How can we go about using social media to even get some hospitals to be responsible for some of their acts and some of their inefficiencies? How do we do that?
So the broad spectrum of regulation, I don't like the word enforcement, but enforcement is one function under regulation anyway. But the broad spectrum of regulation starts with the patient. We must never forget it, right? Now, for the hospitals that don't care, we are entering the era of the patient, right? It's the patient's era now. And aggregators and even our data protection agencies coming to terms with the fact that the patient is going to own their own data. And you know what that means? It means that, and it's been done in South Africa already for years. I can, on my app, have all my lab results, all my diagnoses, everything, just like Dr. John was saying, and the patient will call you. So it means I can port. I can get up and say, doctor said something that doesn't make sense. Okay, doctor, no. If I say no, we'll fight. You won't see me again. And until we start to see that healthcare is a business, with a social slant, but it's a business. And like any other business, you have to have customer service, you have to have quality outcomes to attract patients. Don't worry, I don't bother about hospitals that don't care. But on a regulatory side, like I said, the regulator is always playing catch up, and that's a problem. So there has to be strengthening of, and I've been involved in projects strengthening healthcare regulators, strengthening regulators on not just the clinical governance, right, but also the data management, the policy making, and then enforcement. Now you have to create a system where there's transparency. Transparency is the major problem with regulation. If I come and I can shut down hospitals as a witch hunting exercise, right? And I let the ones that are even doing worse go, then people don't have faith in it. I need to be able to be transparent and allow the patient, so if there's complaints, 1, 2, 3 about this guy, then what are the KPIs? And go to the website. So I know a farmer in Lagos has a website where you can go and see whose license is up to date. I'm not sure if that website is up to date today, but they have a website. So before you walk into a hospital, go and check if they have paid their license for 2023, and that's regulation. If they are not up to speed, then why walk into the hospital, right? So the regulation owes the patient that responsibility to be able to say who is in the good, who is in the red, just like MD can and doctors' licenses. Some doctors they're not up to date on their licenses. You'll be surprised. They are running the hospital, but they're not up to date. So the regulator has to be able to handle that. In a country where data is difficult, where Evan is different from Evans, this is very tough. Let's tell ourselves the truth. It's very tough. In a country where we don't have a single identifier, ask Dr. John, I will tell you, if you mess up with your license in the US, you're finished. So your license is your life. But here I can come back and come with another license and come as somebody else. And that's the problem. So these issues are multidimensional, until we have that unique, look, when we have that unique identifier, I can even lend money to a doctor to buy an ultrasound of 20 million, whatever he wants to buy, a Rolls Royce ultrasound of 40 million, knowing that he will pay me back because of his license. Do you understand what I'm saying? If you get those unique identifiers, everything will move. Me, that I'm a funder, I will want to fund hospitals easily. So the question is, look at it from all dimensions, all stakeholders, patients, regulator, policymakers, and say there are gaps in the system that don't allow us the ability to enforce. The guy can leave Lagos and go and start practicing in those states. Nobody will know why he left Lagos. Do you all get what I'm saying?
Can I just add, can I just bring a bit of balance to that, sir? I had that, you see, the mindset about the Nigerian health care space. When I left the country the second time in 2014, it was. But coming back in 2022 till date, I'm amazed at how far the healthcare space has improved. We're not there yet, but I must say we've made some advancements. For instance, I'll tell you, if you're before the end of December, you must have your license for the next year. At least you must have paid for it, at least where I work, or else you're not going to get your salary for December. And unless you have your license, you're not getting your salary for January. And that's because the MDCN is making it mandatory for you to get that. So that's not something that was there before. But I just want to encourage us that there are some changes happening in little pockets in the system. It's probably not so apparent there, but it's happening. I must say between 2014 and now, our healthcare space is not what it used to be. We've moved. Thank you.
Let me just add
Okay.
just 1 minute. Listening to that, I think we should also encourage our doctors is continued medical education. It's what you
That's
learn
it.
in medical school has changed in 10 years.
Mhm.
We have to do it regularly. In fact, for me, almost every day. We have to.
Yeah.
Because again,
Yeah.
it's all monitored. There's actually, you can go to a site to see which doctors are doing it or not. It's important too.
And thank you very much.
Thank you. Thank you so, so much. This has been super enlightening. There's still so many questions that we've not been able to touch on. I literally just got a post that was just posted on Guardian about how WHO has advised that countries avoid recruiting doctors from Nigeria just because of this brain drain. And, you know, there are conversations around that I would love for us to continue, as well as some of the questions we've not been able to answer. So what we're going to do, just to keep this conversation ongoing and to please plead with our speakers to work with us with this, is we're going to repost that post on our Instagram page at Pistis FDN. We would love to hear your comments on there, and we would appreciate if people who haven't had their questions answered can put their questions at the bottom of that post to continue conversations going. And we'll plead with our speakers to please just help answer any questions that you can on our Instagram page at Pistis FDN. So we'll share that post from Guardian, and then we can continue the conversations around this on there. I know that many people want to share this webinar because it's been incredible. It's going to be on our YouTube page as well, Pistis Foundation YouTube, as well as our previous webinars. So please, maybe in the next day or two, it will be uploaded on. Please share with members of your contacts who you think would have loved to be here but have been unable to make it today. And as we round up, I just want to say a huge, huge thank you to Dr. Faith, Mr. Fisayo, and Dr. John. Thank you so much for taking out time out of your busy schedule to educate us today, to share your knowledge, and to really impact us. We really appreciate it. I think on behalf of everybody here, on behalf of Pistis Foundation, the board, the founder, and management, as well as all of our volunteers and beneficiaries, would like to say a big thank you to you. If everyone can just join me in putting a little clap in the chat section again, or on our pages, to say thank you to each of our speakers. We appreciate your time. Thank you very much. This also would not have happened without particularly the members of the health team of the Pistis Foundation who have been involved with the planning and preparation of this, including our moderator, who is part of that team, the health team. Thank you for everything you've done to make this a reality and to make it a success, as well as the communications team as well of Pistis Foundation. Thank you so much for everything. We really appreciate you. Thank you so much for all you've done. And finally, to everyone present here, without you, this would not have happened. Yeah, the reason we're doing this, we hope it's been impactful. Thank you for your comments. Thank you for your questions. This is not the end. Please continue to share them on our page. If you're not following us, please follow us at Pistis FDN on Facebook, Twitter, Instagram, LinkedIn, and YouTube. If you have any further questions or anything else you'd like to ask, please share those as well. Thank you so much, and do have a wonderful evening. Thank you.
Okay, so we'll be sharing the link to the Instagram page in the chat room. Please, if you have the link, I shared it with you right now, Louis. If you can copy it and paste it in the chat room so that everybody can just click on it and just follow the Instagram page ASAP. I think does anyone have the link? Please share it in the chat room, please. Thank you so much. Yes, Louis has done that. So you can just
click
on
the one
link
for Instagram, but it's Pistis FDN for all social media, Twitter, Facebook, LinkedIn, and on YouTube it's Pistis Foundation. So please look out search for Pistis Foundation to follow to subscribe to our channel. Thank you.
Okay, so there'll be a recording to this, right? Will it be on the YouTube page too?
It will be on YouTube, yes.
Okay, so as many of you that are asking for the slides or access to the recording, you can actually find the recordings on our YouTube page. Yes, please. We'll have sessions like this every quarter. So please just follow us and join our social media handles and platforms so that you can have access to future webinars like this. Thank you so much. Thank you very much, everyone. It was good to have you.
Thank you, everyone, and do have a wonderful evening. Thank you.
Okay.
Thank you. Have a great day. Bye.
Bye.
Thank you, everyone.
Thank you, Dr. Faith. Thank you.
Thank you so much, Dr. Faith. God bless you.
Thank you too.
Thank you so much, Mr. Fisayo, God bless you.
Mr. Fisayo.
Thank you so much. Great having you all here. Thank you. Thank you so much. Yeah, thank you, Dr. Faith.